Okay, so the next presentation is from Dr. Mark Gilchrist on the safety and efficacy of OPAT/HITH. Mark is a consultant pharmacist, infectious disease and stewardship at Imperial College Healthcare NHS Trust. He's a council member of the British Society of Antimicrobial Chemotherapy and co-chairs its UK OPAT initiative. He's a senior honorary lecturer at Imperial College London, together with being a spokesman on antimicrobials and fellow of the Royal Pharmaceutical Society. Mark has particular interest in antimicrobial stewardship around involving systems and processes that affect local, national and international AMR. His clinical interests, of course, include OPAT, but also tuberculosis and critical care. I've been very lucky to have met Mark quite a few times, most recently at a conference in South Africa, and I really enjoy listening to him talk. I think he's a very engaging speaker, he's very knowledgeable, he's aware of the issues for his areas, his topics of interest, the global issues associated with it, not just those that affect his local practice. And so I'm sure we're going to have a really interesting presentation from Mark, and so could you all join me in welcoming him?
Okay, morning everyone. Thanks very much, Jason. Thanks to the organisers, and thank you for you guys for turning up. So I'm going to chat to you for the next 20-30 minutes or so around safety and efficacy of OPAT and HITH. A lot of what James has said is I'm going to touch on. There's not a right answer, so if it makes you feel slightly uncomfortable or questioned anything I say, then please do come forward and we can discuss it at the end. I'm going to talk a little bit about the growth of OPAT, where we are now in 2019, and it's relevant because it affects where we are in the safety of OPAT and how efficacious it is. Looking at some of the evidence and evidence gaps, and then the next step in OPAT. So I've got a different definition of James's OAT. I'm more COPAT, and I'll come to tell you about what COPAT means a little bit later. But the evidence has really grown in recent years for OPAT services. So we know it started in the 1960s, and there's been about 400 and odd OPAT publications to date. Most of them were demonstrating a proof of concept approach, sort of accepting it as a form of healthcare. Is it safe? But actually, over recent times, we've moved to looking at service evaluation. So looking at those specific disease, patient populations, adverse events, and outcomes. So is OPAT safe in modern healthcare versus the setup from previous? And as James alluded to, there's been some national guidelines that have come out, both in Australia in 2002, but in the UK, and the UK guidelines have literally, the update, the 2019 guidelines from the 2012 have just been signed off. So they are winging its way to a journal near you soon. But they've tried to be unlike our American colleagues, and I'm not wanting to disrespect any of our American colleagues, but they try to be a bit more practical and tangible to the working environment. So yes, they're based on evidence, but they're also based on a little bit of pragmatism as well of how OPAT services should be run. Brazil and Spain have also been in the field for giving guidelines as well. But as well as those national guidelines, there's the case series, and again, Australia, UK, US, and Spain have been very much at the forefront of delivering case series over the last number of years. So we've spoken a little bit about telemedicine. So we had the pleasure of Paul Ingram actually Skyped into our conference in the UK in December. So we tried to use a little bit of telemedicine the other way for him to tell us about healthcare in Australia via that route. But it's applicable to other countries as well. Pediatrics is having a sort of resurge of where it started in the 1960s. So there's a lot more around the governance angle around pediatric OPAT. And then you're starting to see these risk models come out around 30-day unplanned hospitalization, around IV rates of infection, so adverse events with catheters that have come out from London-based groups, and also touching on antifungals. Now, I'm not going to talk about any more about antifungals because it's in the program, but it's just to say it's there. And this debate about adverse events it's really topical. If you start looking at the replies to the IDSA rates and risk factors document, there's quite a few rebuttals, there's quite a few discussions about the statistics that have been used and the rates of adverse events that you have. So whilst these papers are great, they're informing the literature, my suggestion would just be follow up on them and see what the replies are from the authors when you get a counter argument. But certainly the US has seen lots of staphylococcal infection and treating that in outpatients, which has been useful. And very recently in January, the Spanish talked about endocarditis and doing that, treating endocarditis patients in an OPAT setting, as well as their registry that they've now got up and running. And France, Ireland, and also the Netherlands. Netherlands talking about impacts on patient teams with infectious diseases teams running OPAT services. And a little bit closer to home in Asia, there's been some work done around is OPAT a missed opportunity for some of the countries in the Asian continent, and also how do you treat intravenous drug users. So a lot of people don't treat intravenous drug users through OPAT. My local practice or our local practice back home is we do treat intravenous drug users, but as James said, you need to be a bit pragmatic and have your rules around what you do. But you can treat them, and we've treated about 3 or 4 successfully in OPAT. And this has really been around changing populations, and this is where the safety aspect comes in. We have organisations that are changing in terms of staffing and continuity of care. We have elderly patients. We've got more complex comorbidities, and actually we've got more complex patients than we've ever had done before, and we've got an earlier propensity to send people out who are maybe they're less well-planned referrals that we get. And the landscape in the UK to Australia is very similar. Decreased bed base, increased waiting times, and even last night on the news I heard about cancelled operations in Sydney hospitals. So it's very relevant, and the spotlight on AMR that we have. So all of those things together make a very tricky balance in terms of OPAT and the efficacy of it. So you have your nursing staff, you have your medical staff, you have your pharmacy staff. So humour me with my Lego men and ladies. You have your surgeon and you have your patient. So it's about safety. Our primary concern is about safety, the resources that we have, the monitoring, the antibiotic choice, the patient selections that we have. But also you have efficacy as well. So you have the financial aspect, you have the length of stay, quality of care, quality of life. Now James touched upon patient satisfaction, but actually quality of life scoring is actually really important. It's something we don't do very well in the OPAT community. And then you have that awful moment where you have to go in front of your board and say how good your service is, and that's around the governance aspect. So governance it bridges both of those around outcomes, indicators, your unintended consequences, and antimicrobial committees or whatever committee you have within your own organisation. So it distills to 5 main points, is what I'm really going to talk about OPAT team structure and service structure, patient selection, the way we deliver antimicrobials, and I'm not going to talk about the stewardship angle because that's for the follow-on talk, monitoring and clinical governance. So there is this growing evidence that supports formal OPAT services and structures. The references are there, and you're welcome to have the slides afterwards. But when you start to look at this, having formalised services allows you to rationalise treatment. It allows you to provide safety. So in the first study that had over 500 patients referred to the services, 50% was around safe management of those patients. And then you also get regime simplification, which is around 40%. And that's sort of similar depending on where you go in OPAT circles. Having clear clinical and managerial accountability is important. And I'll come on to that in a second. And then there are also various studies that say, well, I've just mentioned regime simplification. Actually, OPAT and HITH services do a lot more than that. And one of the postulations around that is around that they do a more holistic care. So they look about social aspects, they look at the logistics of working on OPAT, And certainly when you look at the data, the knowledge of antibiotics isn't the only thing that OPAT services do. So there is potential value outside of just the knowledge of OPAT. And then there's the Canadian studies which look at formalised OPAT services, and actually if you do have those and you have structures in place, you avoid patients coming back to the ED. So this is a Canadian study which looked at around 100 patients, and in those 100 patients, 60% of them without a formalised service ended up back in ED with either complications. 25% of those patients were readmitted. So it's a very good paper if you're trying to convince managers that formalising services or having structures around services is a good thing. And then the US has delivered a number of surveys around the differences between non-specialised OPAT services and formalised services. And this really is around tracking adverse events. It's around looking at patient outcomes. And where you don't have the formalised services, or you don't have someone taking ultimate responsibility for your patient, you start to see cracks in the system. So you start to see patients fall through, you start to see adverse events that aren't picked up, you start to see difficulties in communication, and James alluded to this, around people having to change their workflow and process. And then when you compare infection-led services versus non-infection-led services for OPAT services, actually, not surprisingly, those that are run by infection specialists tend to have greater monitoring and greater guideline adherence. And those that don't have infection-led services, when you put an infectious diseases pharmacist or infection nursing staff into that arena, actually you increase the monitoring. So it's a case for change. And it's more important, I guess, than it's ever been, because there's lots of services that are developing in the community now. So whilst we inherently had hospital services in the UK and Europe and the US, unlike Australia where you have the health in the home models, we have more patients moving and transgressing to primary care-led services. And that means our communication has to be really top-notch. And there's some evidence now coming out around actually simple checklists about making sure that you've taken out the line in a patient. So it sounds silly, but every MDT we have, and every week we say, you're discharging the patient, is the line out? And it's a bit like kind of the airline industry in a way. Somebody has to say yes, and when was it? So we never assume. And we never assume because we've had the episodes where the line's been left in, the patient's walked into the car park, and they've collapsed with gram-negative sepsis. Okay, and when you have things like that happen, you put checks and balances in place. And actually patients quite like having information. We've given them patient information books, and actually they didn't, so a bit like the maternity books. Patients, we found it in the corridor, they don't like them, so actually keeping things simple. And there is a lot of evidence now pointing to the novel approaches of how you manage patients for safety. So telemedicine, and we're now doing Skype calls with our patients to sort of check in on them. Because there's a lot of information for patients to take in on your first attendance. And we looked at this about 10 years ago, identifying risks of OPAT. So we broke down all the stages, we had patients in focus groups, we had various health disciplines in the room, and we came up with 6 sort of areas of which OPAT might potentially go wrong. It sounds terrible, so we went to the extreme. And this was using, again, airline industry methodology for looking at failures. So this was failure mode effect analysis, where it broke each section down and worked out why would this go wrong? What could go wrong? And I know that writing's a bit small, but it's really to illustrate the point that every stage you get to, what happens if your patient doesn't turn up? What happens if they don't have a phone? What happens if they don't have running water? Okay. Transport for us is a problem in the metropolis of like London. We don't have car parking issues because nobody can drive into central London, but we do have problems with transport and patients not turning up, or what happens then. So patient selection is really important, and I'm not really going to go into the traditional style of patient specific criteria, but there is a growing evidence around patients who are elderly, patients who've got diabetes, with vascular disease, who need a little bit longer for the assessment processes than most. They can't just be put onto an OPAT program and discharged from the hospital as quick as others. And there are various publications around the failure rates go up in these populations unless you have systems and processes in place. And then the other angle is around the infection-related criteria, around have they had prior antibiotics before, what's their initial response been like, and as James has alluded to, the introduction of oral antibiotics, are those available? And in colleagues down the road from us in London, they've just recently published 30% of their patients that they went to assess for IVs for going home on the OPAT program didn't actually need them. They converted them to orals or stopped them. So that's 30% of patients who would have been put on a service if it wasn't controlled and regulated. So it's important to realise that. And I guess, you know, we are in a new era of stewardship and OPAT, and we've had a step change in longer-acting semi-synthetic glycopeptides that are on the market. So we've got aritevancin and dalbavancin that are certainly coming to the field, and our clinical experience has grown with the older agents. They're not that old, but daptomycin, teicoplanin, if you can get it, or ertapenem, continuous infusions and infusion devices. And there's a growing evidence around, particularly ertapenem. We're seeing a lot more adverse events through ertapenem and hallucinations and elderly and populations, and what do you do? So that's growing, and we know that at least 25% of the patients, when you look at the OPAT data, and there's some HITH data in that as well, they will develop a complication at some point. I guess it depends on how good you are at evaluating complications. So they can range from very mild LFT changes to renal function changes, which some services class as an adverse event, to life-threatening line infections. So recently we've had in our service line leaks, so midline leaks. We don't know why that's happened, but we've literally had about 15 line leaks in the last quarter. We're not sure why that's going on. So they tend to happen when you get new staff. That's not about blaming anyone, but it's about new processes, new systems, a change in your service. But that hasn't happened with us, so we're scratching our heads. And really, it's about the MDT approach. So, you know, having your nursing staff, your pharmacy staff, your medical staff talking to one another, and being able to voice. So there's a flattened hierarchy in the MDTs, and everyone's got a voice, and everyone should shout out, because these patients come once a week, and they need to be heard. And again, you know, this idea about long duration, James alluded to, but in the HITH program, you've written about it, so I'm not making this up. This is published data, where the mean duration of intravenous therapy was 7.5 days compared to inpatient therapy, which was 5.8 days. And there's a bit around, is this due to less frequent reviews, strains on the system, not reviewing them as often as it should do? It's for debate. I can't comment because I don't know the data as well, but it certainly starts to ask questions about the financial models. And whether you do laboratory monitoring, whether you do testing, it's shown in the data that if you don't look at your patients and look at their blood monitoring, it's an indicator, an independent risk factor for readmission. And adverse events can happen at any point. So there's American studies which show that actually you're likely to get an adverse event within 2 weeks, or you can get it within 4 weeks, which is the latest studies there. And it's worth knowing what your adverse event rates are. So if someone was to ask you, what would you say? And so that then comes on to benchmarking of data and making sure you have a safe and effective service. So people collect OPAT episodes and the usual stuff. I would say try and think about the unusual stuff that will try and help you grow your service. So people think about the types of transport we use, how often do we give district nursing for antimicrobials. So in London, we've just commissioned a study where we're looking at our district nursing colleagues to see when they give our antibiotics. Now again, that's not a criticism, that's to help them to provide more funding for our community nursing, to say actually we need more nursing staff in the community, or is it around trying to train our patients up better and give them pumps and support them to alleviate the time of our district nursing colleagues to allow them to see other patients within the catchment area. So it really is working within primary and secondary care to try and create that balance and try and be an advocate for each other's discipline, really. So in the UK, we've developed a national outcomes registry. So I spoke about this a number of years ago, but actually it's now grown to over 12,500 patient episodes in the system itself. It gives you patient days saved versus episodes, so not surprisingly diabetic feet are in there, cellulitis, bronchiectasis in terms of high patient days and numbers, but it starts to give us an average or a mean length of treatment for some of these conditions that we see. So if we just take cellulitis, over the years where we didn't have as much uptake, now we treat cellulitis for about 6.5 days, and for the first time it went under 6 days in 2018, and I'm sure it will get shorter. But it allows you to have a benchmark against your services for a range of conditions. And you know, I've just plotted out here the osteomyelitis, cellulitis, and bronchiectasis that we're starting to see more of. There's a whole other battery of conditions that we treat, but actually they do make up sort of a third of our conditions that we treat across England, Scotland, and Northern Ireland. And the drugs are the same. You know, we treat once daily agents when we probably shouldn't do, but you're starting to see the new dalbavancins creep into Scotland, the oral agents starting to creep in, and then there's something very strange in Northern Ireland where they're doing augmentin as a first-line agent. So there's nuances. Adverse events are captured, so we start to get an idea of what our total reactions are. So our line reactions across the UK is about 3% of all episodes, 4.3% for drug reactions occurring. And we can break that into paediatric and adult and start to really look at what's happening. The reason we've only chosen those 5 criteria for drug and line is because they were the most common at the time. But there's obviously something else happening, the fact that the other column is higher. So we need to go back and look at that. And then the adult and pediatrics both have outcomes associated with this. So these are national outcomes that have been recommended. I have to say in the 2019 guidelines that are coming out, these recommendations are completely out. And we've come up with some new sets. And I'm not going to go into those because you'll have to read the paper. But it's a lot more detailed, and it will take into account patients who die on OPAT or who are palliative, who their intent is not to survive an OPAT journey. And palliative OPAT is a whole different talk. But at the moment, patients who come onto service with a palliative condition who go on to die get marked as a failure. And that's not a failure of the OPAT service. That was the intent of the journey. So there are services that are being marked unfairly, I think. And then patient experience, again, it's all part of the safety and efficacy argument, but there have been 2 really big studies looking at quality of life, and they're very nice, discrete studies where they've looked at one paper looked at 37 qualitative interviews, and that was around strengthening family support, around making sure that they had the close attention of a one-to-one within the OPAT environment, and ensuring that their needs were met. And it's something that we don't see very often. And then the other was a structured set of interviews, a very nice discrete project that looked at 28 adult patients. This was done in Leeds in the UK, and had focus groups of 4 patients, focus groups, and they identified the 2 key themes, which were fundamental aspects of care. So, i.e., it's a bit, they wanted to know if it was safe to be at home, or you can still go home and not feel great, and how does that work? How does it feel if you're a patient? And then clear communication that we've already spoken about, and having that desire. And those are open access papers. You can access those in the BMJ around how they looked at that. And there is flexibility in the models that they talk about. So they talk about a nurse going into the family home gives greater reassurance, but actually they don't. The data is not there to say one model is better than any others. So actually all models are pretty much valid in that. And then just to sort of conclude really, so so I think the term OPAT is going to disappear. I don't think it will be with us in a couple of years' time. And a lot of people have said that with Aviva coming out and that it's the death of OPAT, and OPAT service is going to pack up, and I'm not going to have a job to go back to. I don't agree with that. I think that's a very narrow view, and I'm happy to be challenged on that. I leave the country on Saturday, so you can say what you like. But complex OPAT, a complex outpatient antimicrobial therapy, I think is the term that we're going for in the UK. How do you monitor people who make the switches? How do you monitor people on high-risk antimicrobials? 20 to 30% of our OPAT patients now are on complex orals, and it's amazing how many get QT changes, who get LFT dysfunctions, and how do you monitor those? And how do you get the partnership with primary care and GPs to monitor those, and the infrastructure set up, and so costing is of course there. But there is a growing evidence for IV to oral switching, whether it's bone and joint, whether it's endocarditis, whether it's intra-abdominal infections, a whole plethora up there within adults and pediatrics. So we've got to be cognizant of it. And I just put this up this was shown to me by one of our colleagues in the UK. And if you look at, ertapenem has got 2 interactions listed. Okay, but actually if you use Cipro as a step down or alternative, you've got 36. If you use ticaplanin, which we do in the UK, 0, and if you use a combination of Rif and Doxy, you're having to think outside the box slightly. There's more things that could go wrong. And I think people are used to thinking oral is better in terms of side effects. But look at the Aviva study and start looking at the detail of when patients got adverse events, and similarly with linezolid. So we are in new times with OPAT. The safety data is there. We are expanding into new territories such as acute medicine and ambulatory care, and telemedicine. And how do we make sure that the stewardship and governance and outcomes and safety netting of our patients are there? So all the infrastructure is there, but it's how do we model ourselves in a new era? So individual patient management is important, around reviewing everything that's on the screen, making sure that organisations have accountability and processes, and IV to oral switch programs is important, and making sure that your hospital supports you in what you're trying to do. Some people have suggested that actually anyone who's failed, it'd be interesting to know actually, anyone who fails OPAT or HITH in your organisation, how many of you do a root cause analysis as to why they failed? Put your hands in the air. 1, 2. Okay, so I'm just putting it out there as these should be treated. If you got a hospital bacteremia, someone would look into it and that people would be all over it. So why does that not happen in an outpatient setting? And then making sure your staff are fairly treated and that they have the same options for education as those in an inpatient setting. They don't get forgotten about. But having medical, nursing and pharmacy, flattened hierarchy, disciplinary services within your organisation is important. And those that don't have ID-led services, how do you link with those, and how do you treat people with the respect and clinical skills that they have to offer within an OPAT setting. If you want to know more, we've developed a MOOC about this, so it's an online learning course. So it's been successful. It's been downloaded in Australia quite a bit. But it says 2 weeks, but you can do it in your own time. But it basically gives you videos and infrastructure around how OPAT services could work and some real practical on the ground. It's got a lot of people from Scotland giving some advice. So sorry for if you have any objections to Scotland, but they're there. And there's a new MOOC coming out about IV to oral switching, which will be with you in a couple of months time. So lots of people to thank. There's a huge program that goes on behind the scenes in the UK. All of these people and the people back at base that make it happen in my team. So thanks very much, and thank you for listening.